Just giving everyone a couple of minutes to get into the webinar. People are rolling in slowly. Good afternoon, everyone. Welcome to the Gender Equity Education Series and the final installment of Support, Prevention, and Creation. This was a series on sexual harassment and misconduct in academic medicine. I'm Ann Doherty. I'm the Gender Equity Liaison for the Office of Diversity, Equity, and Inclusion and the chair of the Gender Equity Steering Committee. And this has been a really wonderful series in which we looked at first the personal impacts of sexual harassment, then we moved into the epidemiology of sexual harassment in academic medicine, and we then reflected on the role of workplace culture in allowing or preventing sexual harassment. And today we have a nationally known expert to share her knowledge and experience on this very important topic. I want to send a shout out to our co-sponsors for this series, the University of Vermont Medical Center, the Division of Emergency Medicine, and the Departments of Internal Medicine, Pediatrics, Pathology, and Obstetrics and Gynecology. And before we get started, I want to recognize our Dean, Rick Page, for his unwavering support for gender equity at the Larner College of Medicine and give him the opportunity to say a few words. Dean Page.
Thank you so much, Dr. Doherty. And I'm going to keep this very brief. I've been looking forward to hearing Dr. Hayes' remarks today and can't wait to just sit back and spend the next hour listening to this very important topic in terms of gender equity in healthcare. I do want to acknowledge Dr. Doherty and the entire task force or the steering committee for gender equity within our Office of Diversity, Equity, and Inclusion. This is such an important topic, and I'm so pleased that Dr. Doherty has taken the lead and is providing us with this ongoing discussion and conversation and commitment to this very important area. With that, I'm going to just thank Dr. Hayes for joining us today. I hope your flight was comfortable and they fed you well in the air. And seriously, I'm so glad that we're able to do this and actually make note of the fact that these sessions are in some ways more equitable and that people don't have to travel to an auditorium, but actually are able to join from their computers. So again, everyone joining us today, thank you. This is part of professionalism. This is part of who we are. And with that, I'll kick things back to Dr. Doherty and look forward to hearing Dr. Hayes' remarks. And thank you again for joining us today.
Thank you, Dean Page, and thank you for your support again. I'm going to pass this off now to Joe Conant, who is a member of our Department of Pathology and who is the co-chair of the Education and Professional Development Working Group. Joe?
Thank you. So it is now my absolute honor to introduce Dr. Sharonne Hayes. She is a professor of cardiovascular medicine at the Mayo Clinic in Rochester, Minnesota. She founded and maintains an active clinical practice in the Women's Heart Clinic at Mayo and was appointed as their first Director of Diversity and Inclusion in 2010. Under her leadership, the Mayo Clinic has been nationally recognized for its diversity and inclusion accomplishments. Dr. Hayes leads efforts aimed at optimizing women's health and applies her considerable expertise and knowledge to advancing health and workforce equity. She has led efforts to optimize women's health and clinical practice and research activities at Mayo and has developed programs to enhance their professional and personal development, as well as mentorship of women and minority physicians and to mitigate unconscious bias in order to promote a more diverse workforce at Mayo and in the field of medicine as a whole. She serves as a founder of Time's Up Healthcare and is a tireless advocate for safe, equitable, and dignified healthcare workplaces that promote high-quality patient care. Dr. Hayes' research includes sex and gender-based cardiology, spontaneous coronary artery dissection, health equity, participation of women and minorities in medical research, healthcare workforce equity, and the utility and optimal role of social media in clinical practice, medical research, and health education. You can see that our interests are broad. And with that, please welcome Dr. Sharonne Hayes. Today, she will speak about her work and dedication towards eliminating sexual harassment and gender inequity in healthcare.
Thank you so much. Now, I am assuming that many people who are on this call have attended many of the other excellent sessions that you have had over the past few months on this topic. I feel a fair amount of weight and responsibility to try to, as I've been told, sort of pull it all together. So one of the things I thought I would seek is to put the common pushbacks to making changes in this area so that you have some of the myths and the busted myths about how you can have a conversation with colleagues and others about the need to make these changes, to tell you a little bit about the experiences we've had, particularly focused on addressing sexual harassment and how we've been since 2017 here at Mayo. And then end with some additional things about achieving gender equality or equity. But we'll start with harassment, that not necessarily a great term. I have no disclosures other than the fact that I thought I'd be a doctor really early, I guess, as my parents snapped this picture. So one of the reasons we're talking about this, some people, the business case is increasingly, we know that the leadership style that is, I hate to stereotype as a diversity equity, but there are ways that in general, women and men approach leadership somewhat differently. And it has been both in the business world and the health world found that some of those characteristics, such as being more risk appropriate as opposed to risk taking, less hierarchical, looking for bottom line results, all of those things are more likely in women. And we have seen that in some of those healthcare systems that have, and countries that have been led by women across the world, they have had less issues related to COVID-19. And whether it's a gender issue or not, it is an observation. There's also the issue that at least there's a hint that women do as well, and in some cases potentially better in providing healthcare, particularly to certain groups. One that was highly publicized was in my field of taking care of heart attacks in women in Florida, where they found that the best outcomes for women were when the emergency room doctor, the emergency medicine doctor, was a woman as opposed to a man. And the two things that were found that men did better is when they had more female colleagues and when they had treated more women. So again, having more women in the workplace as physicians and also equitably placed could improve healthcare for women. I think the other is just practical. The healthcare workforce is aging. And so looking at where we need to go in terms of recruiting women and making them leaders to replace the retiring boomers that are leaving professions. Over 60% of my specialty, cardiology, are over the age of 55. Oops, sorry. Now, even before RBG passed this week, I had several of her quotes in this talk. I added a couple of more, but I think that making the case that women are here to stay, when I'm asked when there will be enough women on the Supreme Court, and I say when there are 9, people are shocked, but there'd been 9 men and nobody ever raised a question about that. So let's talk about the problem, and I think the specific problem that I want to talk about is sexual harassment, because that's what we're going to start with. This is one of the problems. So some of you may have seen this, which got lifted up on Twitter. So the black and white photos in this was a textbook of examination in orthopedics. That particular textbooks, the illustrations and photography had been called out as somewhat inappropriate. And then the color pictures were the next edition. When this was lifted up, the publisher pulled it off and made an apology. But the fact that this could go through publication speaks to, I guess, a lack of sense that there's anything wrong with the sultry eyes in having an arm exam. So in 2018, and this is great reading. It's a bit slogging through, but there is a chapter with all of the issues, more like an executive summary. But the National Academies of Science, Engineering, and Medicine came out with a consensus study report about sexual harassment of women, particularly in science and medicine. It was a landmark study with recommendations because it was very evidence-based. And there were some characteristics about organizations that had higher levels of sexual harassment, organizations and professions that tended to be very hierarchical. Medicine, anyone? Male dominated. So many of our specialties, including my own, cardiology, is still very male dominated. Many of those were setups for having higher levels of sexual harassment. There were also a number of recommendations for going forward. And I think importantly, there was data collected about the prevalence and the severity of sexual harassment, which was a surprise to many. The other thing that was helpful here was that they defined sexual harassment and helped, I think, many people conceptualize why maybe we thought it wasn't that big of a problem. So the public perception of sexual harassment is really the more severe form. It's the sexual coercion. Now, these things happen, but fortunately are relatively uncommon. So, and are more common in actually research labs than they are in the broader field of medicine, but threats to one's career. If you don't do this, I'm not going to sign off on your promotion or your PhD thesis, or retaliation in terms of poor performance levels, or unwanted sexual attention, repeated asks for dates. What's actually far more common is gender harassment. So definitionally, these are, hyper attention to people's bodies, comments about don't you look good today, with with vulgar words or slurs, insults that are aimed at mothers, and then just in the presence of women, sexually explicit jokes and other things, which make for an environment that can be very oppressive for men and for women. And then gender discrimination, and we'll talk a little bit about that toward the end of the talk. So I wanted to talk about some of the myths that actually the NASM report did bust, but one was harassment is a minority issue affecting just a few overly sensitive women who otherwise are unfit for the job. Well, in fact, we see this in medicine. This is a medicine problem, in part because and that's why we have Time's Up Healthcare, because when they looked at students and their experience, including undergraduates and graduate students, medical students had the highest rates of gender harassment and unwanted sexual attention compared to other graduate students. It is pervasive. Many of you may have seen some of the results of this study. It was a survey of over 7,000 men and women who had been sitting for an exam. And this was at the end of the exam, and it was optional. It was not, and so the fact that the response rate was so high is impressive. But 70% of women surgical residents had reported mistreatment, which was defined as sexual harassment, gender, racial, parental discrimination, or verbal, emotional, or physical abuse. About 30% of the respondents were women. And I think strikingly, in terms of sexual harassment, 20% of women had experienced it. I think it's also important in this discussion of who they're getting it from. Although disproportionately, and we'll see some other data, this comes from senior people, attendings, people who are in supervisory or power positions. Patients and patients' families perpetrated 30% of this sexual harassment. Gender discrimination was experienced by 65% of women, so 2/3 of women. And also half of that was due to patients and families. So there's a whole nother talk about how we can deal with that, but I think it's an important consideration going forward because it is a source of mistreatment and distress for women. And then pregnancy and childcare discrimination as well. So in another study, so that was surgeons, this is at Mass General, a smaller group of individuals, oversampled for women, almost 200 women, but men and women, residents in surgery, medicine, and anesthesia. And what they found is the vast majority of individuals had witnessed or experienced gender-based discrimination. So this is not harassment necessarily. I think importantly, you see the dark bars as women, so they outpace from everyone. And so you've got on the other side, you have who were the perpetrators. Again, visitors and families and patients were second only to nursing in terms of this gender-based discrimination. And importantly, and this is in every study, less than 5% of these that were witnessed or experienced were reported to anyone who could do something about it. I'd like to invite you, if you would like to submit questions, if you have questions or comments about anything that I'm saying, to put them in the chat or in the Q&A. We're going to try to monitor those. And if I can answer them in real time, we do have some time at the end for questions, but particularly if it's something that's relative to what I'm talking about right now, just access the Q&A. Myth number 2, if harassment is indeed identified, the perpetrators must be just a few rotten apples or bad apples within the organization. We hear that about that a lot, about bad actors. Oh, you know, that was just a bad police person. That was just a bad, a terrible person who led that lab and abused that individual. Now that we've gotten him out of the way, everything will be fine. I think that what we know now is it is an organizational climate that sets this up. So here at another organization, University of Michigan, they asked faculty about whether they had witnessed or experienced unwanted behavior over the past year. So about half were women. And what they found in terms of that women, 80%, and men over 60% had witnessed or experienced it. So what they then looked at, was it from insiders, meaning staff, residents, or colleagues? And that was more common, but again, we see that there was some significant impact from patients and families. And although sexual coercion was quite low and not present among patients, again, that is the most severe and the one that is of most concern. So it's very prevalent. People see it, they witness it, they don't report it. And so it's so prevalent, but another myth has been it doesn't cause physical or psychological harm and as such is not a priority. Well, that's one of the reasons for Time's Up Healthcare, because what this study, the University of Michigan study, and others have shown is that those who are victims of sexual harassment or gender discrimination often have fairly significant impact to both career and psyche, mental health, job satisfaction. Some even leave the field altogether. One of the Time's Up founders had been a resident in a program and experienced such sexual harassment that she ended up leaving the field, went back to get her law degree with the goal of addressing these issues. So we lost a great physician. And then finally, it definitely affects people who are honestly our best and brightest, K awardees who are experiencing sexual harassment. So the vast majority, only 5% did not experience sexist remarks of behavior. Over half felt like this injured their confidence in terms of being able to be a researcher and independent researchers, and they felt that it affected their career advancement. So the impact is very real. So if you put yourself in the place of an individual who has experienced this, whether it's on the wards or in the office or in the lab, the cath lab, the echo lab, these are individuals who sometimes start dreading going to work. And if you are a faculty member who is a great teacher, you may just be so down that you don't teach anymore, you don't make the extra effort, that discretionary effort that we depend upon in healthcare settings. I'm going to take a question here. I'm curious about the nursing category, harassment, discrimination coming from nurses. If so, and assuming that the nursing profession continues to skew female, that demonstrates the way that women can perpetuate the discrimination they themselves may experience because it's built in the system. Absolutely, great point. And so one of the things we have observed in terms of not so much sexual harassment, but gender discrimination is among our female surgeons that they have, they feel that among nursing staff and some of the surgical allied health staff, that is actually where they are experiences the most pushback, often more likely to question their capabilities, microaggressions, and other of those types. So I do think that we can think of a lot of reasons that might be the case, but I think changing the system, and we are actually working with our nursing leadership to try to change the climate and the habits of that. And that's why I think it's important to get data. I will come back to saying data drives a lot of things that we do in medicine. And it certainly has helped in our experience by having data, because we can act on data as opposed to anecdotes or deluding ourselves that, well, that's not, yeah, it's happening everywhere else. It's happening in surgery or University of Michigan, but it's not happening at Mayo Clinic. That is a way that we need to get our own data. And so that's what we have endeavored to do here at Mayo. So we've talked about there are very negative effects that really become pervasive across an organization. So sexual harassment, we can frame this as a severe occupational hazard analogous to other workforce dangers. It's also research misconduct. And that's one of the things that the NASM report said, is that if in research, a PI is found to be a predator or sexually harassing individuals, or making it difficult to do their job on the basis of gender, that consideration of taking away funding or calling the research that comes out of that lab misconduct. And obviously can lead to adverse patient outcomes if people aren't at their best. So that's why Time's Up was formed by a group of individuals. There are a core group of 7 individuals, and there are about 50 of us who are considered Time's Up founders. So looking at this, and this builds on the last questioner, this is a systemic issue. It is a part of the fabric of medicine that we need to work on. And that we need to work on this as if it is a disease. So this was at the founding launch of Time's Up Healthcare, which was about 18 months ago. So I understand that University of Vermont is a signatory for Time's Up Healthcare. And this is basically what you said, if not exactly these words, these were the general words, that you're going to say that sexual harassment has no place in your workplace, that you're committing to preventing and protecting and aiding those who are targets, that you want everyone to have equal opportunity, so this gets into the equity, and then finally that you're going to measure and track sexual harassment and gender-based inequities. And that's a tough one because most of us, including Mayo Clinic, we're not doing that. So we commit. So I'm going to shift gears a little bit. I'm going to look at this question: where do you suggest we draw the line institutionally with patients and families who are guilty of gender-based discrimination? Healthcare workers often tend to dismiss patients' comments and behaviors. They are our patients and we're here to care for them. That's actually a whole nother talk. But in 2019, because I will just address it, you need a policy and you need to adhere to the policy, because we who are providing healthcare, we are there for the patient, but there are behaviors by patients and their families that are erosive and actually create a hostile workplace for which you as an employer are responsible for. So we put together a policy and a lot of training to help our staff, because the victims are primarily younger and people of color and women for the patient. And so many leaders at Mayo were even unaware that it was going on. So I'm going to put that aside, but happy to deal with it in more detail later if that's of interest. So one of the things we realized when the Me Too movement came out, and we reflected, and I'm talking to HR and our personnel, that maybe we might have a problem here at Mayo Clinic, because we reflected on our processes and we had different ways that we handled sexual harassment. They bubbled up through different areas in the organization. Each of our sites, we have a big site in Arizona and in Florida and in Minnesota, we're handling it independently, and therefore the risk for having variable outcomes or not addressing things was fairly high. So we looked at our processes, felt that our processes needed work, and also reviewed all of our policies and other things. So we did outline, and if you have interest, more deep interest, we published earlier this year on our process and some of the early outcomes of this. But I wanted to share. So first of all, our policies needed beefing up. They were okay, but they were not explicit and often didn't directly address sexual harassment. So we updated our policies. We then developed, and I say we because this is a big team. It's HR, it's physician leadership, it's legal, it is a number of folks, some of whom needed some upskilling because we had not done consistently investigations of these types of allegations. So we developed a procedure for investigating all claims of sexual harassment that was very specific. We trained a group, so we basically have an investigator team that's made up primarily of HR personnel, and then made sure that we were adhering to all of the laws because we've got employees in multiple states. Very important to engage senior leadership because if they didn't think this was important, you know, and I think that people are motivated by different things, but certainly wanting to make sure that we have the best environment for our staff is the most aspirational, but avoiding lawsuits was obviously in the Me Too era was also certainly a consideration. The other part is important to train all staff, both of the existence of the policy, of how to report, of where to report, and as well to help people who may be well-meaning and are perpetrators but don't mean to be. So one of the things as I've given talks to more general audiences, including more senior men, particularly some of them who are in private practice, they kind of push back about some of the behaviors that we are saying are risky or unwanted by perhaps some of the women that they work with, because it was, you've changed the rules, this used to be okay. And I often push back in a really gentle way and I say, in some cases, it really was okay, right? It was not, the women weren't bothered and you thought it was a nice thing to do to put your arm around them or to say that. But I think also acknowledging in the Me Too era, things have changed. And I think that's an important acknowledgement for folks. So our goal is to thoroughly address the allegations and then really reporting, protecting the reporter, but also protecting the person who is alleged to have misdone, the perpetrator or alleged perpetrator, and really be fair on both sides. And that's really important if this is going to be successful at an organization, because if it becomes a witch hunt or people perceive it does, then you will not get support from leadership. So we assign each one, we offer employee assistance to all parties that are involved. And ultimately, we use a fair and just culture grid to help us once the investigation is done. So as we do this, we determine the danger level initially. That's like one of the first steps. Is there danger? Meaning, by this reporter coming forward, is she or he, sometimes it's predominantly been women, at risk? If that's the case, we may put the person who is an alleged misdoer on administrative leave. And we also look at mitigating factors in terms of, are they a learner, in which case Title IX needs to be activated. We look at the severity, any history of past actions. And then we come up with, once we've looked at that, whether we're going to coach, whether there's going to be a formal warning, or whether termination and possible law enforcement. So this is a busy slide, and I'll just say this is sort of the framework. And I would draw attention, so the actions that we might take, coaching or counseling, just notifying, a formal notice, a final written warning, with or without suspension, termination, or termination plus criminal or professional sanctions. So we look at what is the effect, the result of this, whether it's negligible, minor or moderate, or major, like harm to a patient, harm to Mayo's brand. We look at whether it's at-risk behavior, meaning this was risky behavior, but and it shouldn't have been done, but it wasn't deliberate, malicious, and therefore coaching might be appropriate, to reckless behavior. And I think that differential between at-risk and reckless, we use that also when we are investigating breaches of our medical record by employees. Was this like I slipped into the record, or I did something by mistake, I just need some coaching about what the rules really are, or it's still a violation, but do I need coaching versus I went in and I got a friend's phone number so I could stalk them. That would be very different. So we, if a physician, I'm just going on around a bit more before I take questions. If a physician is being terminated, there's an automatic separate peer review. And they have the authority to re-interview everybody who was interviewed the first time, and any employee, non-physician employee, can request this. We report to this if state law requires it, and then we do some due diligence at the back end and debrief leadership. We follow up with the reporter. We respond to, we decide how we're going to respond to external requests for letters of response, letters of recommendation, and a quality review. What could we have done better? And we have learned through this many things, and some things that we could have done better. This is published. I'm not going to show things. It's business confidential, all of the details of things. But as you can see, early on, after we announced this policy back in late 2017, we had a marked uptick and reported in reports. This has gone down and stayed relatively stable. We look at who's reporting, who are the victims, who are the perpetrators, was it substantiated or not after the outcome, and importantly, look at trends. So I get a monthly report on this. I'm not directly involved in the process. So I'm going to take a couple of questions. When somebody takes the brave steps to stand up and open up the conversation about a problem, they're often seen as a threat to the culture or stability of the working environment. Seeking advice on how to support the person who takes brave steps. That's great, and I kind of I didn't skip over that, but the support for that really does come from, I think, transparency of the process. I remember when this first came out, I mean, I've been at Mayo for a long time, there were two dominating senses of this. There was a great deal of cynicism. All right, Mayo's been saying that they're going to do something like this all along. Sure, it's just because they had witnessed perhaps an environment, a lab or a work group that had egregious behaviors for years, and nobody had done anything about it, and everyone knew about it. So they assume, of course, that the organization has sanctioned that. So it's really important. So we had that group, and then we also had the very fearful people. A lot of men said, this is a witch hunt. I can't say anything anymore. I can't be nice to anybody. I can't even say something nice about somebody's dress. And again, we wanted to reassure them. And I think the thing that helped us the most was, one, trying to be really transparent that this was a sincere leadership effort, but you can only reassure people, is when we started posting the data. So at the end of 2017, we gave a review. It was posted not externally, it was our intranet, it was a news story, and it outlined how many, it's sort of like this, and I'm going to show you, but it was in prose, but basically how many investigations, how many were substantiated versus not, and what the outcomes. And I think when people read, you mean you fired X number of physicians for this, there was a realization that people are taking this seriously. I think for the other side, the people who thought it was a witch hunt, on all of sort of overall, about 2/3, about 65, 70%, depends, running average, are found to be substantiated. That does not mean, if it's unsubstantiated, it can mean two things. It could mean it was simply really a misunderstanding. So it wasn't sexual harassment, and often coaching or just a conversation between the individuals. Sometimes, unfortunately, unsubstantiated has been, we cannot find enough evidence to substantiate it, but we strongly believe that it may have happened. That's sort of a minority, the unsubstantiated. But that's very helpful when you realize that not 100% are taken to termination. That would have been the other fear. So I think supporting the individual, very importantly, and we've built that team to do so. In developing this just culture framework, how were victims' wants or desires for justice taken into account? They are not specifically taken into account. And that's one of the beauties of the structure, because it means that there will be a relatively, hopefully, if we all sort of follow this and all talk to each other and look back at prior decisions, that we are consistent with dealing with our staff on both sides. and that the punishment is appropriate for the crime, for the egregiousness, the number of people that were affected, et cetera, as opposed to the wishes for the outcome by the individual. So we track it. We did not track it prior to 2017. The policy and the practice is enterprise-wide. There are local investigators, but the group all talks to each other. As I said, 2/3 have been substantiated. The vast majority have been individuals who have a position of power over the others. The accused and that are substantiated are disproportionately male physicians. So I think we keep separate stats for our physicians and our allied health personnel, and disproportionately these are male physicians. Now, if you keep these data, then you know who your targets for education are, because some of even the unsubstantiated ones showed us that there were opportunities for coaching of physicians. For the most part, and many of these, particularly early on, there was a dysfunctional work culture that was present in that lab or work group, and often for a long time. And so sometimes there have been leadership transitions as a result of this. Even if the division or department leader was not the issue, they were permissive. And so that has also been a way to either coach them or reduce that. The other thing that I won't go into detail about, but significant relationships in the workplace, we now have a more straightforward policy. So we're a small town with 43,000 employees. There's a lot of husbands and wives and brothers and sisters and sisters and sisters that work at Mayo Clinic, some in the same area. And so making sure there is a way to disclose those relationships and a way to mitigate them that doesn't harm either individual's career is sort of a separate talk. So this is not an actual dashboard. It has some anonymized sort of, but it gives you an idea of what we see every month. So we look at what are substantiated and unsubstantiated. We look at the current year risk level. So here you would say the risk level, and by risk, that means egregiousness, risk to Mayo, risk to individuals. And we also track how long it takes to close the reports. Obviously, you don't want to do this hastily. You want to do it effectively, but you don't want to drag it on. It's too hard for the individuals involved. So we've been trying to decrease the time for closing the reports. We look at what the outcomes are, as well as who are the individuals, whether it's allied health, physicians, contractors, or students. Here's a question: when you've uncovered a dysfunctional work subculture, have you been able to rectify things via training alone, or do you find that leadership staffing changes are required? They sometimes are. So we have moved staff, we have let staff go, we have a rotating leadership process here at Mayo. So division and department chairs rotate about every 8 years. So it might be accelerated if it is deemed that this is more of an issue related to leadership, but education alone, particularly for the subculture, is usually insufficient. How many reports at Mayo come from bystanders versus victims? We are trying to increase bystander action, as many people are, with bystander training and getting people scripts. But without the victim coming forward, we don't take action. So we have to have, it's not a passive process. It may be a bystander encourages someone to report something that happens to them. Freud, the great question, which I've not yet been able to answer despite my 30 years of research into the feminine soul, is what does a woman want? Well, we can't be universal, but one of the things that certainly most people, women and men, want is equity, whether it's equitable pay or equitable opportunity. And the literature suggests that in areas, this dysfunctional work culture, that it's not just harassment, right? So those areas where harassment is high, it's often in a system that supports inequity in other ways, whether it's compensation, promotion, opportunity, or leadership. And I think I'm going to shift gears and just talk a little bit of some of the things to think about. And I know you've covered some of these over the past few months. We do know that there are multiple places that women fall out of the pipeline altogether, the healthcare pipeline, but specifically fall out of the leadership trajectory. Women are more likely, and particularly if you are a woman of color, so the intersectionality magnifies this exponentially, but isolation and exclusion, sometimes differential access to resources and opportunities, being able to travel to a meeting pre-pandemic if you had little kids, for instance, mistreatment by allied health professionals, and nursing is one of them, lack of mentors and support. So all of these things are kind of in the background, and we should be talking about all of them in whatever ways that we can address them. And I think importantly, defining equity and equality. So equality sounds great. It's equal access and opportunity. But sometimes you have to treat people differently for them to have equity. I often give a healthcare example. If I treated every woman with heart failure exactly the same as I treated a man with heart failure, the outcomes would be very different, and for women worse, because women have a different type of heart failure. They more likely have heart failure with preserved ejection fraction, whereas men with reduced ejection fraction. So targeting therapy so that everyone has a great outcome is important. So that means assessing each individual needs and treating people differently, sometimes in the workplace, not just in the hospital. I think the other message is there's been a lot of well-meaning efforts to improve women's leadership capabilities, their executive presence, lots of things. But if the culture does not support, we can improve that woman all we want. If the culture does not support, when she comes back as an improved leader, support her being able to use those leadership skills, then that's a problem. And it is a glass or whatever type of ceiling. And so focusing less on fixing the women and more on addressing the issues in our systems. So I wanted to speak briefly about pay. I know nothing about your compensation plan, but I think that virtually every place every look at women physicians, starting from straight out of residency on up to leadership, there's a pay gap. And I think it's really important to look at it because it is really erosive to women. And I've talked to some women at other organizations who found out after working for 20 years at a place that somebody who was in the exact same role, who was a man, was making $10,000, $20,000, $30,000 more per year. And that makes you think completely differently about who you work for. So encouraging gender pay equity assessments to make sure that everything is fair. We did do that. We're a pure salary model, and there was some concern, and I had pushed to have an outside. I was pretty confident. I'm married to a cardiologist who used to work at Mayo, and I looked at our pay stubs. I was pretty darn sure that there was pay equity, but we wanted to make sure. We had an outside firm come in, and we found that it did. That's that finding. But the other thing that we found is, one, there's many things that can adversely affect salary or total compensation. The lack of transparency is one of those big ones. But the other finding from our study was, yes, if you ask, are women at Mayo Clinic, physicians at Mayo Clinic, paid less than men at Mayo Clinic? The answer is actually yes, because there are more women in primary care and in fields that have lower compensation and fewer interventional cardiologists and neurosurgeons. And so really, when pay disparity, even if we're all paid the same for doing the same work, women won't achieve parity in the ranks of the most highly compensated specialties or leadership until they get into those. So women will only have true equality when the men share with them the responsibility of bringing up the next generation. So another equity issue, which certainly I am watching my younger male colleagues stepping up and wanting to be more a part of their family lives and do that work, but still, there is a motherhood penalty, an unconscious bias. This study that I sometimes will quote it's not in medicine, but the only difference between the resumes was member of the PTA. And for women, that actually was a detriment. They were less likely to be hired, and they were more likely to be offered a lower salary, whereas for men, it was the opposite. I guess they felt that they were good family men. And so there is a fatherhood bonus, and we have to remember that as we're thinking. And I think the most important thing that I would say for leaders who are on this call is ask her, if you have a great opportunity, a leadership role, a stretch assignment, and you say, wow, Jane is so busy. She has 3 little kids and a husband that travels all over except during COVID, but you know, she's homeschooling them now. I guess she's so busy, and then you pass it to someone else. I would just encourage you, let Jane say no. Jane may say exactly what you just said. I am tapped out, but please think of me for next year. But she might also want that so much, that opportunity. So that I think if there's an action item, it is not assuming that women are less likely to want to take these. There is a stigma of being a mother in particular, not just a stigma, but some real challenges. We found it as living in a small community. We have a number of our surgical trainees, and they're dual trainees. So they're both working at 80 hours a week, often the same 80 hours or the opposite 80 hours, and then they're tired. And, you know, if we want to retain them, we need to look for how we can support them during this important time. There is a disproportionate impact for women versus men in terms of childbearing as well. And this was a recent study that showed that for men and women physicians, there was still about almost 2 hours or an hour and a half more work done by women than their physician spouses. So even though we'd like it to be equitable, figuring out, this is not for University of Vermont or Mayo to figure out, but addressing it and acknowledging these differences and hoping that we change society going forward. Women also, and I don't know about University of Vermont, but in many organizations, they do more what is called office housework. And that is often mentoring, planning the Christmas party, doing other things. So figuring out a way to equitably distribute those. And this was not physicians, but if you look at it, UMass, white women and women of color were far more likely to be spending time doing mentoring and service to their university. And men of color were doing a lot of mentoring as well. Looking for ways, many of you have seen this meme, it really was a meeting of Manos, but looking for ways to increase visibility of women. If you are leadership, if you're going to change things, you have to be with the people who hold the levers, RBG. I think remembering for those who are feeling threatened that the rise of women doesn't mean the fall of men. And in fact, some real he for she's have come forward in terms of being able to articulate. So several of these individuals, many of them are cardiologists actually, but I put this quote, and he puts this in any time he is invited to be on a program or a panel where it's all men. I'm honored to be a part of the panel. One caveat, as you may know, I have a rather public position that I will not participate in all male panels. For a panel of this size and topic, it would seem straightforward to ensure there are at least 2 women on the panel. Less than that, I'll have to bow out. Let me know if you have any difficulty. I'm happy to help. So just sort of being proactive, and so really recognizing the men who have taken these steps so that others will model their behavior or see it as something that is feasible. I think we have the unconscious bias. I pick on Delta and cardiology a lot, but in this case, Delta has done this twice, but this is a physician who was in training in OB-GYN in Texas, and there was an emergency on the plane, and she came forward and said, I'm volunteering, and she was told to go sit down. They wanted a doctor. So recognizing our own unconscious biases, which is again, a whole nother talk, but addressing them and acknowledging that they exist and sometimes disproportionately adversely affect women and people of color. And call women doctor. Probably the most impactful study that I have published in a very, very low impact journal was when we looked at our own grand rounds and found that if you were a woman giving medicine grand rounds at Mayo Clinic and being introduced by a male introducer, you had a 50-50 chance of being called doctor if you were a woman. That was really striking. It was a way to, that data was a way to change a lot of hearts and minds, including guidelines for introductions of grand rounds at Mayo Clinic. I think the other thing to acknowledge is, particularly in some specialties, women are onlys, and there is some data about women when you are a first or an only in a group or a profession, there are additional challenges that you must overcome that often disadvantage you. She knows that she'll be judged differently, and that can bring about stereotype threat. Often her abilities will be judged as one-offs. Well, she was lucky that time, and they are often targets of microaggressions. And then the differences that they have are often not just interpersonal differences, like, you know, we have lots of men, they're all different from each other, but her differences may be attributed to being a woman. The other problem is that new policies that perhaps should have been in place for a long time may be blamed on her, like a maternity leave policy. If you didn't ever have a woman in your practice and you didn't have a maternity leave policy, then the fact that everyone's being disadvantaged by sharing call is now sort of targeted at her, as opposed to this is something we probably should have had for a while. And then we have the tightrope. Oh, sure, she figured it out and got the job done, but is she likable? Ms. Sisyphus. Is we do know that women who are leaders in particular are often have this tightrope balance of being competent versus likable, and they know it because they're walking this tightrope and they know they have to be likable or no one will follow them. But to be likable, often if they're too likable or agreeable, then they're viewed as weak leaders. So this is a challenge that women and people of color often have to navigate. And it's often a no-win situation. Why is it important? It's exhausting. It can be very exhausting, and actually then it is a self-fulfilling prophecy, as well as labels and stereotypes. This she's too, how these words used to describe women, they're virtually always used to describe women in the workplace and very uncommonly used to describe men. And women know this, and so they become exhausted and sometimes their performance suffers. It's also important in terms of giving feedback to trainees. When trainees do not get proper feedback, or they get feedback that is not actionable, and I won't just say trainees, but this was a study that looked at feedback to trainees who were struggling, and men who were struggling as residents got very specific and honestly very actionable, whereas women's advice was all over the place. So this matters because in general, women get less feedback, informal and formal, which is what they need to succeed. They have less access to leadership. And I am going to, because time is close, and I'm going to skip forward. So I'm going to wrap up with RBG, to fight for things that you care about, but in a way that will lead others to join you. And I've heard that quote so many times this week about moving forward in a really positive way. And so as organizations, we need to acknowledge that there's a problem. Leadership is so important in driving change, and we have to address the structures in our organization and in medicine in general that perpetuate these inequities. These are specifically looking at recruitment and hiring, evaluations. Are they fair? Are they, is there gendered language in them? Do we have equitable opportunity for authorship? Do we just include our cronies, our in-group to add to the authorship? And influence, and looking at career flexibility as something that's good for medicine, not just good for women and families. So I will wrap up now in talking about how you have gone through this journey. We are going through this journey as well, of looking how we can make the workforce more equitable, not just for women, but for everyone, and addressing sexual harassment. And I will stop there and take questions that are in the live feed, as well as those that, Anne, you want to toss to me.
That's great. Thank you so much, Dr. Hayes, for a really engaging talk, very comprehensive, and a challenging topic to encapsulate. We did have a question in the chat, which was asking about the proportion of men versus women in this particular audience, and is this typical, and how do we have more men in the room having this conversation? And I'll just say I did count, it's 14% men, though I will say that the majority of those men are in leadership positions in the institution. So I think that's positive. But what is your opinion? How do we get more men in the room?
So I think that it's on us to invite them in. I'm director of diversity inclusion. We're changing the name of the office to equity, inclusion, and diversity. So we're putting diversity at the end. But I can tell you from many of my colleagues who are well-meaning and want to help, but you say the word diversity and they said, that's everybody but me, if you're a white guy. And so I think we need to make sure that we don't make it, that we welcome them in, that we make sure that they know that we cannot do it without them and without strong male leadership. I think also making it personal and not blaming. It can be very threatening, just the word sexual harassment. That's a scary topic to men and women. And so, but I think focusing on equity, focusing on behavior, professionalism, and the things that we all have in common, and bringing men in to help them see how they are valuable partners in addressing this issue, as opposed to who we are afraid of and or who we are mad at. And I think that's it's a fine line, because that sometimes is reaching out and inviting your male colleague to come, to do that. It's not easy, but it is something that we absolutely need to do. The very first video that Time's Up Healthcare had at the launch was a bunch of men talking about Time's Up. It wasn't a bunch of women talking about Time's Up. It was very specific. It was why I support Time's Up, because of my wife, because of my colleagues, because of my patients. But it's just important. I specialize in heart disease in women. I can tell you very often when I give a talk on heart disease in women, it's mainly women providers, whether it's the nurses and female cardiologists. So I do think that we need to reach out.
Well, thank you so much for that. And I'll give a shameless plug, which is the next topic being covered in the Gender Equity Education Series is actually allyship. And so we will be having this conversation. Let's see, we have another question. Let's see.
I think it's Sarah Mel who
Yes.
Who has a great comment. It is the privilege of being the dominant. If you are white, you don't think about your whiteness very much. If you are male, you don't consider your gender very much. If you are whatever dominant culture, whereas if you're Black, you wake up thinking about race every day. If you're a woman, you think about gender a lot of times, particularly in medicine. So I think also helping, that's a great insight, because it helps us understand why men don't see it maybe as a deal. I've had men who've said things that achievements, for instance, aren't that big a deal. People who are close, and it was an achievement that I had, which was to get a full professorship. I didn't actually think I would be a full professor before I retired, and I had several well-meaning individuals who said, it's not that big a deal. They were all men. And once I was promoted, I realized what a big deal it was. And I was kind of mad. And because one person was somebody who really cared about me. And I thought, well, was this being patronizing, or more likely, as I talked to people, it wasn't a big deal, because they always assumed that they would make full professor at some point in their lifetime. And so, it's not that big a deal to graduate from college if your parents are both college educated. If you have never had a family member go to college, it's a really, really big deal that your kid graduated from college. So it is a perspective.
Agreed. Perspective is primary. We're just at 1 o'clock right now, so I want to be respectful of everyone's time. I do want to let folks know that this was recorded, and the hope is to put this up on the ODEI, the Office of Diversity, Equity, and Inclusion's website. I want to thank Dr. Hayes so much for being with us today, and let everyone know that the series on allyship starts on October 15th at the lunch hour, and is an introduction to bystander training. So stay tuned for more information on that. Thank you so much, Dr. Hayes, for taking the time to be with us.
Take care. Bye-bye.
Bye.